I am Dr. Monica Minger. I'm the host of Let's Talk Fertility tonight, and we're going to be talking all about fertility. We're going to dive deep. And so, just want to start off with a couple of questions. Have you been trying to get pregnant and can't find anyone who's going to search for answers as to why you are struggling? Maybe you've been told that IVF is your only option. Or maybe you've already tried IUI or IVF and have not been successful with conceiving. We're going to discuss ways that you can be proactive in seeking out restorative care for fertility by getting to the root cause of your fertility concerns and working together with our proven approach to conceive on your own without the use of artificial reproductive technologies like IVF or IUI. Make sure that you stick around until the end because I'm going to be sharing real data outcomes and compare how our approach has a higher pregnancy rates, higher live birth rates while minimizing complications like miscarriages or twin gestations, all for a fraction of the cost compared to the cost of IVF. So let's jump in and get started. So a little bit about my background. My name again, Dr. Monica Minger, and I have founded Radiant Clinic, and we are a women's health clinic that works to help promote natural menstrual cycles to improve health and promote fertility. I'm a family medicine doctor by background, and I have been in the Cedar Rapids, Iowa area since 2012. In addition to my family medicine training, I've received additional training in multiple different methods of restorative reproductive medicine, including Creighton model or NAPRO technology as a medical consultant. I am also a FEM medical consultant and neofertility medical consultant. I founded my clinic back in August of 2023. And around that same time, also started the Cycle Wisdom podcast, which you can find on all major podcast platforms. I put a little asterisk there because throughout the presentation, you're going to see different references. So if you want to hear more about a particular topic that is on a slide, you can refer back to that particular podcast episode to hear more and to have an in-depth episode that talks all about that particular issue. So we're going to start off with some true or false in regards to infertility because there's a lot of misinformation out there when it comes to infertility. So true or false, evaluation for fertility concerns should start only if I've been trying for more than 1 year. This is false. We're going to talk in a little bit about why waiting a full year may not be the best option for you. True or false, female factor is more common when compared to male factor. Now, this is a trick question. It might be maybe, and we'll talk a little bit about why that is, because in our practice, we evaluate both the male and the female factor side of things because we're looking at your fertility as a whole. True or false, infertility affects 1 in 6 couples. And this is true. This is a pretty common statistic. A lot of people are aware of this, but it's not something we talk about all that often. So if you think about within your circle of family or friends, 1 in 6 is a fairly high number. Now, this doesn't always mean that these people end up not having children at all, but it does mean that at some point in their life, they're dealing with fertility concerns, whether that's subfertility or secondary fertility or primary infertility, not being able to get pregnant in the first place. And true or false, infertility requires me to do IUI or IVF. And this is a big false. We're going to break this down tonight because I think a lot of times people hear that their only option is to go through IUI or IVF. This is the only thing we think will actually work. And although this is a very common approach in conventional medicine, we're going to talk about some other options that you have in order to be able to show you that there are better ways forward. So I always like to give a little bit of a disclaimer. The names, the data, and charts that I'm going to share with you have been de-identified. So sometimes people say, oh my gosh, that sounds like my story. It's not, I promise. Everything has been de-identified. The information we present here today does not constitute medical advice. And so I recommend please work with a licensed healthcare professional for appropriate evaluation and treatment recommendations customized to your needs. So the case that I share tonight with you, you may have some of those same diagnoses or may think that you have those same things. It doesn't necessarily mean that the same treatment options are going to apply. So it's really important to make sure that we get you the appropriate evaluation that you need for your unique situation. So I'm going to be sharing with you tonight Kay's story. Now, Kay came to me and she was 37 years old. She had never been pregnant before. She had stopped birth control about 4 years ago because she and her husband were trying to conceive. 1 year later, after she had stopped birth control, she went to her OB doctor and said, "Hey, we've been trying to conceive for the past year, haven't had any success." And so she was immediately started on Clomid for the next 6 months. Over the course of that time frame, Kay ended up spending about $500 out of pocket between her office visits, labs, follow-ups, and the medication. After 6 months on Clomid with no pregnancy, the OB doctor said, well, we have to stop that, switch gears. She was then referred on to IUI, or intrauterine insemination. She and her husband went through 6 cycles of IUI, which resulted in 4 rounds of intrauterine insemination, and their out-of-pocket cost was about $1,800. They did not conceive on any of those cycles either, and she was sent on to IVF, and she was told, this is your only option. This is our last chance in order to try and get pregnant. This is it. And so over the course of the following 6 months, she went through 3 rounds of in vitro fertilization, and their out-of-pocket cost was somewhere around $15,000 to $20,000 per cycle. And so that total cost $45,000. At the end of that nearly 2.5 year journey, there was still no baby. She had spent out of pocket over $47,000. She had significant side effects from the medications, from hyperstimulation. She was emotionally exhausted and given a diagnosis of unexplained infertility. So why did meds fail? Why did the IUI? Why did IVF fail? We oftentimes hear so often, these are the things that are going to work, and this is just what you need to do. I would refer you to a couple different podcast episodes I have listed here, number 46 and 77, that talk about different things as far as why some of these issues fail. The first and most common reason that we find is that there was no true diagnosis made for Kay as to why she had fertility troubles in the first place. Nobody had stopped and paused to say, why is this couple having troubles, in order to do that deeper dive and in order to treat what was actually going on. Because there was no diagnosis, there was no targeted treatment. And that also made it very challenging to know, what are we supposed to do? And oftentimes we find this means a very standardized approach that is not unique to your situation. When she was going through IUI and IVF, the overarching theme is to try and force implantation to occur and force that hormone stabilization by providing mega doses of hormones and ovulation stimulation. And in Kay's situation, there was underlying factors of ovulation dysfunction, implantation issues that were not corrected. And so all of these things, no matter what conventional medicine tries to do, it's not going to be enough to overcome and to help conception occur. In Kay's situation, lifestyle changes were not addressed either. Her doctor had said, well, just make sure that you sleep well and that you're eating healthy, but nobody really took the time to walk through that with her to say, hey, how are we going to help you do that on a regular basis? In her situation, they also didn't take into account the full picture of the male factor. And so her husband had seminal fluid analysis testing done, was told it was suboptimal, and said, take these supplements, and that's all we need to do in order to make this proceed. And so really needs to say, when we're evaluating this, we're taking into account all of those factors. So if we back up and look at normal fertility statistics, most of the times you're going to be told a standard evaluation timeframe is 1 year without pregnancy. In general, for couples with normal fertility, we see that each cycle you can get pregnant about 25 to 30% of the time if you have normal fertility and are trying to conceive. However, if fertility is normal and you know when you're ovulating or when your fertile window is, over 95% of couples will be pregnant within 6 months. And so in our world, we set that bar a little bit lower and we say, if you are not pregnant after 6 months of what we call fertility-focused intercourse, meaning you are having intercourse during that fertile window, then we want to start the evaluation process that we think there may be something that's going on. Again, 1 in 6 couples will be faced with fertility struggles in their lifetime. That may not be over their entire lifetime, but there may be different times along the way that they have troubles with this. So some questions to ask. How do I even know if I have fertility problems? Again, our recommendation is to start evaluation if you've been trying to conceive for more than 6 months and you know when you're fertile. So if you are identifying, I know when my ovulation is happening and I'm aware that this is a fertile window and we've been actively targeting that time frame for 6 months, it's time to start getting evaluated. Another common question I get asked is, does fertility problems, do those run in families? Now, there certainly are particular genetic conditions that can make fertility more challenging. However, it is not strictly across the board that we say, okay, because my mom had a hard time conceiving, I'm going to have a hard time. We know that things like PCOS, thyroid dysfunction, autoimmune disease, diabetes, some of these can have a genetic link. And while they don't negate the need to evaluate them, we still want to address each of those concerns based on their merits because they affect everybody uniquely. And how common is secondary infertility? So, secondary infertility means you've been able to have a successful pregnancy, and then you try and go back for a second or a third pregnancy down the road. And what we find is that about 10 to 15% of couples will have difficulty getting pregnant even after a normal pregnancy, whether or not it was challenging to conceive or not. So, this is a very real thing, and we want to address the fact that sometimes the way we get there the first time may not be the way that you get there in subsequent times for trying to conceive. So, what are some basic things you can do if you're preparing for pregnancy? The first and probably most important thing is learning how to chart your cycles. Now, this is more than just figuring out when is my period and plugging that into an app. This includes identifying when exactly is my fertile window, as well as being able to identify what is the date or the rough range of dates that I have ovulated. And typically, with charting your cycles utilizing a fertility awareness based method, we're able to narrow that window down to identify that fertility window. And typically, we can identify ovulation within 24 to 48 hours of accuracy. So I can't underscore that enough, is learning how to chart your cycles for some people can be the key in order to being able to determine when can we conceive. Sometimes, though, we find out people aren't having an ovulatory event or maybe don't have a fertility window, and that's absolutely worth getting evaluated for because there are many causes from a medical standpoint that can prohibit that. Other things you want to do when you're preparing for pregnancy, check your prescriptions, check your supplements. I'll go into a couple things as far as supplements that are recommended for pregnancy, but many medications, prescriptions, or over the counter are not considered to be safe when trying to conceive. And so it's a good idea when you're trying to work towards getting pregnant to start getting off of some of those medications or supplements so that you can start things with a clean slate. Consider getting baseline lab testing done. If you're able to work with your primary care physician or an obstetrician or another healthcare professional, it's a good idea to get baseline labs done. I generally recommend at a minimum vitamin D levels, iron, blood counts, and a full thyroid panel. Now, we're going to talk about what to do if you are having fertility concerns. We obviously would expand that quite a bit more. But even if you are overall very healthy and not having any other concerns, these are good things to check. If you are somebody who smokes or vapes or uses recreational drugs, even things like marijuana that can be legal in some states, the recommendation is to stop all of these. Just because something is legal doesn't mean that it's a good idea for pregnancy. And we can find specifically with smoking that this can impair fertility by slowing down how well the cilia move, which is what helps to move the egg along the fallopian tubes. So really important to try and start getting that out of your system. Working towards decreasing your alcohol intake and caffeine intake. Obviously, alcohol is not recommended in pregnancy for the most part, as well as caffeine, trying to limit that. And so if you can start working on cutting those out of your system ahead of time, that'll make it that much easier when you do get to that successful pregnancy. Also want to focus on improving your sleep, managing your stress levels. Sleep and stress are so critical when it comes to managing all of the rest of your hormones. And I'm a fan of saying that there are hormones that can kind of hijack other things. And so cortisol is a great example. Cortisol is a hormone that our body produces, but it also will significantly increase under times of stress. And so if your cortisol is out of range, it will hijack all of your other hormones and make things a lot more challenging as far as to balance the rest of your hormones. And then just do a check-in as far as your diet and exercise. Do I have any foods in my life that maybe I should probably part with? Am I getting regular exercise as far as generally we'll say 20 to 30 minutes of walking on a daily basis? If I'm somebody who's exercising significantly, I may need to cut back on that. We find that if you are exercising too much or too intensely, it can actually inhibit ovulation from occurring. So we talk about modest exercise. Exercise is excellent for many, many reasons, but making sure that it's in moderation. So here's going to be the basic supplements that I talk about. And again, you can refer back to episode number 42 for some more detail on these. But generally, you're going to recommend a good quality multivitamin or prenatal vitamin. methylfolate if not already in your prenatal vitamin. And so a lot of people have referred to this in the past as folic acid. So methylfolate is a little bit different. It is a version of folic acid, but methylfolate is created a little bit differently. It's methylated. And so for people that have methylation problems, so if you are somebody with MTHFR gene mutation, or for people that just have a hard time absorbing nutrients, the methylfolate is absorbed much more readily and is much easier for your body to absorb and get it to where it needs to go. So methylfolate is fantastic. Many prenatal vitamins that are out there now already have methylfolate in that prenatal vitamin. So just check with your methylfolate to make sure that it's in that prenatal vitamin. And if not, then you want to add that in. Fish oil or omega-3 fatty acids, so minimum looking for 700 EPA daily. Now you can get this through many food sources, so whether that's flaxseed or chia seeds or fish or seafood, that's fantastic. For many people though, it's hard to get that amount in their daily diet, and so adding in a good quality supplement for omega-3 can be really beneficial as well. And then the last one we talk about is vitamin D. Now, D3 is the best form as far as being able to absorb it, and you can get this over the counter. Many formulations of vitamin D3 come along with K2, and that helps that you better absorb the vitamin D. Most importantly, I do recommend getting your levels tested for vitamin D. Most people that live anywhere north of St. Louis, Missouri, generally need some sort of vitamin D supplementation, especially during the winter time. But it's also good to just check and see, what are my levels at? Are they adequate? Recommendation going into pregnancy is that vitamin D level should be 50 or above. So 50 or above, in order to help support good health for mom and baby during development. And then any other supplements are going to be specific to your lab results. So I oftentimes see women that come to me and they're on this list of 17 different supplements. And ultimately we end up chopping most of them, because the reality is there's so many supplements out there that we don't know exactly what they do during pregnancy, if they're safe or not. In fact, there are some supplements that are touted to be able to say, hey, this is going to help you with getting pregnant, but in some women, they can actually have the opposite effect. Or maybe you already have hormone levels that are fine and you're adding on this additional supplement that's going to increase that more than what you need. So really, we should talk about targeting supplements based on only what you need and your unique situation, rather than just saying across the board, I need to be on a bunch of different things. So really this basic list here. So let's go back for just a moment to kind of address some basic concepts of fertility. And so fertilization requires three things. Some people think it's just the egg and the sperm. Obviously, that's very important. But the third thing that's required is cervical fluid or cervical mucus. And so a couple concepts here, as far as men are always fertile after puberty. Sperm are produced and available 24/7, and sperm can survive up to 5 days in the right conditions. So if that cervical mucus is present, the sperm can survive for up to 5 days while it's waiting for that egg to be released. However, women are not always fertile, and this fertility depends upon the time of ovulation when the egg is released. Generally, there's a time frame, a window about 5 to 6 days each cycle that a woman is able to become pregnant. Again, we say plus or minus on those 5 days afterwards if the right conditions exist for cervical mucus and there are sperm present at the time of ovulation. So if we're trying to time intercourse, you want to be targeting that fertile window. So any time that there is mucus present is considered a fertile window. However, we know that the most fertile mucus is going to have a few specific characteristics. So things you can watch for: if you wipe when you're going to the bathroom, either before or after urination, and it feels really slippery, that is a good sign that there is fertile type mucus present. If you observe mucus on that toilet tissue and it is clear in color, or you try and stretch it off of that toilet tissue and it stretches more than 1 centimeter, that is also a good sign of fertile type ovulatory mucus. And so targeting that fertile window whenever mucus is present is a great thing to aim for. Intercourse every other day during your fertile window also has some merits. And one of the things that's been studied is to look at how long does it take sperm to recover, to regenerate between episodes of intercourse. So sometimes people come in and they say, okay, we're having intercourse every single day during the fertile window. And there's actually some data that shows it makes more sense to target every other day. That allows sperm time to regenerate. It allows time for the semen to build back up again, get all of its nutrients so that it's able to get to where it needs to go most effectively. So aiming for intercourse every other day during that fertile window seems to have better outcomes. And then one that's probably the most important that we often dispel the myths quite often is that you should avoid most lubricants. Many of them are petroleum based, which can impair the movement of sperm. Now, it is okay to use a water-based lubricant if needed. Pre-seed is an example of this, but even the recommendation is to avoid oils. So coconut oil or olive oil and saliva, any of those can actually be damaging to sperm and are not recommended. So if you absolutely need to use something for a lubricant, make sure that you're using a water-based lubricant if needed, or just go without. Chances are that if you are in your fertile window and there is cervical mucus present, you may find that you don't need to use as much lubrication during that time. So let's switch gears a little bit. We're going to talk about charting and what that exactly means, because I know that's not familiar for everybody. So this is just an example of a chart that we utilize, and I want to orient you to a couple pieces here. So what we're going to see is each of these days is a different day of this woman's cycle. So at the beginning is when she first started with day 1 of her menstrual bleeding and went forward from there. Generally, then most people will see a period of a couple of dry days. In this particular charting type, this is called chart neo or neo fertility. Dry days are shown by this green stamps here. And then she entered into her fertile window, which is this period of blue stamps here. And then what it does is it identifies the last day of fertility or of seeing that fertile mucus is marked as a P for peak day or ovulation day. And then it counts the days after that ovulation, and that's your luteal phase. And so after that point in time, we see a couple other biomarkers that can shift. So this is going to be just the observations as far as cervical mucus goes. This dotted line that we see down here, this is actual basal body temperature. Now, not everybody needs to track basal body temperature, and many people like to add it on, but a lot of people do fine just with doing the cervical mucus tracking. I just like to show this example so you can see how that overlays. And so what we see here is that she had a temperature shift the day after ovulation, which confirms ovulation has occurred. This particular chart also shows an overlay of doing luteinizing hormone urinary metabolite strips. And so she was tracking to see when did she have that LH surge. And so we can see that all lines up pretty closely, are centered around this peak day, in her case, May 27th. We also track and monitor when is intercourse happening during the cycle, as well as being able to track your meds and other symptoms that you may be experiencing. So if you are consistently noticing certain symptoms at different times of your cycle, this becomes a really beneficial way in order to track day to day what's going on. And then myself as a healthcare professional, I can look at this and know at a glance, this is what's going on with your cycles. This is an example of a similar chart where we overlay it on what's going on from a physiologic standpoint under the surface. So what we see here on this first line, these are the changes that are happening in the ovary along this time. So early on in your cycle, you start to have this follicle that develops around the egg. So the egg is this little blue dot that's in the middle. Now this is microscopic, so just imagine, this is very, very tiny. But this growing follicle continues to grow up until the time of ovulation, and then it releases that egg. Now, that follicle that was developing goes on to become the corpus luteum. And so if you become pregnant, that corpus luteum is what stays around and starts to increase progesterone levels to help with the development of a placenta. Other changes that happen that are consistent, estradiol levels, your main source of estrogen, will increase and then takes a sudden abrupt drop at the time of ovulation before stabilizing. Progesterone, which is this purple line, is typically very low, almost zero, up until the time of ovulation, and then it takes off. If we look at the signs and symptoms that are changing as far as your endometrial lining during this time, we see at the beginning, obviously, the menstrual bleed that's happening, and then we see the increased thickness of the uterine lining over time. And then again, if there's no pregnancy, we see that the menstrual bleed begins again. Cervical mucus also is something that increases over this time in response primarily to estrogen levels. And so we see that cervical mucus will increase its stretch up until the time of mucus of ovulation, and then generally that mucus will decrease again. And then the last line on here is basal body temperature, again, showing that generally levels are fairly low until you have ovulation, and then levels increase. And then if you're pregnant, those levels will typically stay elevated. But if you're not pregnant, then generally the temperature drops back down again in order to help a cycle again. So I know this is a very busy slide, and I definitely don't expect anyone to memorize it, but I like to show this because it shows us how we can figure out what's going on underneath the surface at that microscopic level from a hormone level just by observing what we see here on the charting. And this is how it lines up physiologically in order to help interpret what we see on a regular basis. It also allows us that when we have variation from cycle to cycle, as is seen in these charts, it helps us to identify what's going on and how do we time our interventions. So this is another method of charting. This is called Creighton model. And it's a similar idea, except that rather than using the blue stamps for fertility in the middle, Creighton model utilizes these little baby stamps in the middle in order to identify this is what's going on as far as the fertile window. So this is actually an example of representation of different women actually on this chart. Each of them is a different line, showing some different possibilities we can see with infertility charts. So this first one we'll identify is that it has a very limited mucus cycle. So really she only observed 1 day of fertile mucus, as opposed to, as I mentioned earlier, for most women, we see at least 5 to 6 days of fertile type mucus. So this is a very limited mucus cycle, and so a very narrow window in which to try to conceive. Now, it certainly is possible that you could still conceive, but your chances would be much less. This is an interesting one on line B here that talks about, hey, we've got a fairly normal window of fertility of 5 days, but she still was unable to conceive. And so this can be something that we see commonly where we just say, why is this happening? But it helps us to identify what's normal and where we're having issues. Line C is an example of a woman who is not observing anything as far as an ovulation window. So whether that means that her mucus patterns are not great or whether it means she's actually not ovulating requires some additional medical evaluation, but it's really obvious to see it'd be challenging to target and say when she's ovulating without seeing something else other than these mucus cycles. And then line D here shows somebody that has a very short luteal phase. So meaning she ovulates and 5 days later, she starts her next cycle. And so the problem with this is that even if fertilization were to occur, there's not enough time to allow implantation to occur before the following cycle starts. So this is also a flag to say we need to evaluate that luteal phase and see what's going on. So what causes difficulty with fertility? This is really challenging to kind of break down because a lot of times it's not studied well. But when we look in general in the field of restorative reproductive medicine, we typically will find that the female factor is the predominant thing in about 40% of cases. Now, this could be a myriad of different things, either problems with the egg development or ovulation factor. It may be a hormone imbalance or a vitamin deficiency. It could be anatomic issues, so troubles with endometriosis, issues with the shape of the uterus, fallopian tubes, fibroids, polyps, lots of different things. But it's important to know what it is that we're treating because that helps us to target that treatment appropriately. In about 30% of the cases, we find that it's actually just primarily a male factor that's going on. So whether that's decreased sperm counts or motility or morphology, or it could be poor quality of sperm with damaged DNA. And one thing that's important to point out is that if you have a seminal fluid analysis, a general standard sperm test that you would have done, it does not check for the DNA. It does not check the quality of the sperm. So you can have a totally normal count and motility and everything, but if the DNA damage is high, if you have a poor quality of sperm, that can cause significant issues with fertility. And there are no symptoms or signs with that. And so it's important to know and to be looking for that if you think that's part of the issue. And then the other piece for males would be male health or hormone issues. And certainly with that, that can be anything that would be female dysfunction as far as hormone imbalances, vitamin deficiencies. But other things we find in men can be general health concerns. I have found in some men diabetes or high blood pressure or high cholesterol as a cause for fertility concerns or problems with low sperm counts. And then the other 30% of the time, we actually find that there's both male and female factor. And so that's why it's important to know that when we're looking at this, we're evaluating both sides of this picture because both sides play a role when it comes to this. So for more information on this, podcast episode number 62 talks a lot about the different factors that play a role when it comes to evaluating fertility concerns. So that's a lot of stuff, right? And I think a lot of times people get overwhelmed and they feel like there's all of this baggage to carry. How do I know what to fix? And really, what I generally will tell people is we don't need to fix 100% of these things. Primarily, we need to know what we are treating, though. We cannot just say there's a whole bunch of stuff wrong, but we don't know what it is. And we're going to just try and throw things at the wall and see what sticks. We have to know what we're treating in order to move in the right direction. So let's pick up with Kay's story again. So Kay comes to our clinic. First step is we get her charting her cycles because that's not something she had been taught to do. She couldn't tell us if she was ovulating, when she was ovulating. And so we said, okay, let's slow things down a little bit. Let's start with charting your cycles, get things back on a regular routine. So we had her work with one of our exceptional fertility awareness coaches in order to get her charting and instructed on how to track her cycles on a day-to-day basis. The next thing we did is ordered a targeted hormone and complete lab panel, and I'm going to share some of those results with you in a little bit. I also did some ultrasound scans. We wanted to check follicle development in a normal cycle. So as you can remember from that slide I showed recently with the follicle, that's that cyst that develops around the egg when it's getting ready to be released. So we wanted to check and make sure, first of all, that she was developing a follicle, and second of all, that it was a good size and did actually release, because all of those pieces, if there's anything that goes wrong in that follicular development, that can also lead to troubles with trying to conceive. We also checked in Kay's case a hysterosalpingogram to make sure that her tubes were open. So the fallopian tubes, if they are blocked or if they are problematic, can cause some issues. And so we wanted to make sure that the tubes were open before we started further down this path. And then again, put her husband through some of that additional male factor evaluation to make sure that we knew what were the other pieces that were playing a role. So just wanted to compare a little bit Kay's evaluation when she came to see us. Her previous evaluation she had done. She had some lab testing done. So that's these first 6 bullet points here, TSH down through AMH. And this is a pretty standard evaluation that we see a lot of our clients get, is these 6 lab tests. Now, she was told everything is within normal limits and everything was fine, and so she didn't have a problem. She did also have an ultrasound that was done to check anatomy, primarily to make sure that yes, she has a uterus, that yes, she has 2 ovaries, but it was not timed to her cycle, and so they didn't have an evaluation on the follicle development or rupture. So as opposed to when Kay came to see us, we did things a little bit differently. So timed her lab draws 2 different times during her cycle. And typically for people that are having regular cycles, that's going to be one time early on in your cycle. So usually during the days of your menstrual bleed. And then generally about a week after ovulation has occurred. We know that that should be the highest point of when progesterone levels are peaking. And so we want to check and make sure that your hormone levels are not just in normal range, but are optimized during that time frame. Our initial profile includes over 20 different hormone levels, in addition to a complete thyroid panel, evaluation of your adrenal glands, which are responsible not only for stress production, but also responsible for the production of many other hormones, in addition to vitamin levels, and an assessment for insulin resistance. Now, I know this one seems a little bit unusual, but we find oftentimes that insulin resistance can cause ovulation dysfunction, even in people that don't seem to otherwise have other insulin issues. And so this one is an important piece that we evaluate on most of our patients with fertility concerns. And then the additional imaging that we ordered for Kay included cycle-timed ultrasounds. Like I mentioned, we're checking those follicle scans a couple different times during her cycle, as well as that hysterosalpingogram, making sure that the tubes were open. So this is just a sample of Kay's timed lab results. And again, I don't expect for you to see that, hey, what's abnormal or what's normal, but I want to call out that everything that's in bold is either completely abnormal or could be borderline, meaning that's on the low side of normal. And so as we start to look through this and we say, okay, why is there such a difference? Her last doctor had told her all of her labs were normal. And part of this is that we don't look for just saying, what does the lab say is normal? We utilize evidence-based guidelines from Restorative Reproductive Medicine that say, we find best success with pregnancy rates when, for example, your FSH is less than 7. We see best outcomes for TSH thyroid when that TSH is less than 2.5. And so really starting to fine tune some of these things and say, okay, yes, this may be normal according to general conventional standards, but when we look to say, how do we achieve optimal lab levels in order to try and conceive, our targets become quite different. And so, as you can see here, Kay did not have normal labs. She had lots of things that were abnormal that needed to be evaluated and treated further. Now, I do always like to point out when I show my clients their results, this can be very overwhelming. And you can look at this and say, oh my goodness, more than half of my things are going on. I need to do 17 different things. The reality is that oftentimes there is still a root cause for a lot of these things that if we dial it down, we can find, okay, it might mean that there are maybe 3 or 4 lab abnormalities that are caused from this one thing. And so we target that one thing and we say, what is the root cause? How can we address this in a way that helps to improve all of the other lab results? This is the second part of Kay's timed lab results. So this was the second day that we did them. And again, this was 7 days after ovulation. And so I've included here a sample of what we're looking at as far as the blood sugar and insulin testing in order to be able to say, where do we have abnormalities? Where do we see, what does that trend look like? Because even though Kay did not have technically pre-diabetes or diabetes, she did exhibit some signs of insulin resistance. And so it's important that we evaluated that in order to say, hey, there's probably something going on that's impairing ovulation or creating some difficulties, and we want to pay attention for that. The other one that I always like to point out is progesterone levels. So many times a conventional doctor will tell you that at least if your progesterone is above 3 after you've ovulated, that is normal. The reality is that progesterone level above 3 only tells us if you ovulated, yes or no. So if that progesterone level is above 3, it indicates, yes, I've ovulated. If it's below 3, I have not ovulated, but it doesn't tell us what's that optimal range. And so if we're looking for just general good health, the guideline that we look at is 15 to 17 nanograms per milliliter is a good range for just general health. However, if you are trying to conceive, we want to aim for a progesterone level somewhere closer in that 18 to 30 range. Again, we find better outcomes, better success rates for pregnancy when we're able to target that progesterone level being a bit higher. Same is going to apply for estradiol levels. Estrogen is responsible for the thickness of the uterine wall lining, which is responsible for where that baby implants. And so we want to make sure that these levels are not just in an undetermined normal range. We want to make sure that they are optimal in order to improve our chances of conception. So Kay's results and treatment plan. Again, she came to us and her diagnosis was unexplained infertility. And so just by going through the process of doing the lab evaluation timed with her cycles, we were able to identify 6 main areas that needed to be worked on. The first was ovulatory dysfunction. She also had a luteal phase defect, so a problem with low hormone levels after she had ovulated. Insulin resistance, which I pointed out. She also had thyroid dysfunction, adrenal insufficiency, and a vitamin D deficiency. And so the reality is that this is not nothing, right? There's a lot of things that are going on here. And so in Kay's case, we focus on a few different things, and this is pretty common across the board. We always are going to talk about 3 main areas when it comes to what do we do next, because it can seem really overwhelming. So the first area we always talk about is lifestyle changes. Where do we need to make adjustments with your diet, with sleep, with stress levels? How can we help to improve those things? We talk about supplement recommendations, whether that's with vitamins, whether that's with food sources, but how can we help to restore whatever might be deficient specific to your case? Prescription strength medications when appropriate. Oftentimes we do utilize prescription strength medications. And so that's a common misnomer is that a lot of times people think that when we're talking about natural fertility, it means that we're just saying like, okay, get more sleep and take some pills, some vitamins. But the reality is that we do utilize medications, but timed to your cycle. And again, targeting those treatments based on what your body is actually showing us. So Kay's treatment specifically, we looked at dietary and exercise modifications. So specifically because she struggled with the insulin resistance, we did end up sending her to see a dietitian. And that's one of the main things that we have found is really, really crucial when it comes to making any of these changes, is that we include in our fertility package the ability to work with either a dietitian or a health coach, because we realize a lot of this can be overwhelming and we want to try and make those changes sustainable for the long run. Her specific supplements that were recommended, vitamin D, now we talked about that's already one that we recommend when it comes to trying to conceive, but in her case, her levels were low, so we talked about how to increase that. We also utilized myo-inositol, DHEA, and adrenal support in order to help the specific defects we had seen in her lab results. Her prescription strength medications included letrozole, HCG injections, metformin, and thyroid medication. So this is a lot of things that we can do. It doesn't mean that we're taking all of this every single day, but we're timing it to her cycle according to try and help augment and help nudge in the right direction to say, this is what your hormone levels should be doing, and we're going to help move them in that direction. We then adjust medications and supplements each cycle as needed based on results and timed lab draws. So we continue to check timed lab draws, meaning we're following things about 1 week after ovulation in each cycle in order to make sure if we need to make adjustments, can we decrease certain dosages? Do we need to increase certain dosages? And what does that look like? So restorative reproductive medicine, that's the name of what we do. And again, the whole idea is to restore things to a natural balance in order to promote normal cycles, good health, and promote fertility. So we utilize charting to evaluate our progress and assess ongoing concerns. We address these individual factors and diagnoses like we did with Kay. And then create a targeted, unique treatment plan that's adjusted each cycle based on how you're responding to things. We take into account things like if you're having a side effect or a negative effect or not the intended consequence, we want to adjust that each cycle, first of all, so that you're not miserable, but more importantly, so that way we can monitor how is your body responding to these things. And sometimes we're able to then come off of some of those supplements and prescriptions even prior to conceiving because we've corrected those underlying abnormalities. We also always want to focus on lifestyle recommendations because long beyond when you decide, hey, maybe we've already been pregnant, we're done having kids for now, we want to make sure that we're addressing these things for an overall health standpoint. And oftentimes infertility is not just infertility, it's a sign that there's something else going on with your health. And that's really where we want to target and say, how can we help improve your health for the short term and the long term so that we can help improve your long-term outcomes? And most importantly, restorative reproductive medicine considers both male and female factors. And again, I would refer you to podcast episode 79. We talk a lot about restorative reproductive medicine, what it is, what it isn't, and how it can be so beneficial when it comes to this. So when we talk about a general timeline, people get a little concerned because they say, hey, this all sounds great, but this is going to take forever, right? And generally what we talk about is there's 3 different phases of our process. The first phase is that charting and evaluation. So getting a woman educated as far as how to chart her cycles, looping in her partner in order to say, how can we be proactive on this? Doing the evaluation as far as lab testing, initial ultrasounds if that hasn't been done, testing male factor if that has not been done yet. All of that happens in phase 1. So over the course of the first couple of months. Phase 2 is more the intense time of treatment and adjustment. So going over those lab results, being able to say, okay, here's what we're going to do from a medication standpoint, adjusting them to get to a point of where levels are at optimal range for both progesterone and estrogen in that luteal phase to support pregnancy. And then phase 3, we talk about is kind of the fine-tuning phase. And this phase is really variable. It can be anywhere from 1 to 12 months. And again, I'd refer you back to our podcast episode number 67, where we talk about why fertility takes time. And the reality is that many women come to us and they've been struggling with health issues or menstrual cycle irregularities for a really long time. And so sometimes it takes time in order to get things back on track and get things aligned. And usually what we see is that by the time we see that cycles are looking normal, that the numbers as far as lab testing is looking normal, on average, most women conceive within 6 to 8 months after they have balanced cycles. Now, sometimes that takes a bit longer. Sometimes it happens earlier than that. But the reality is this is not a quick fix. This is not just, hey, I'm going to come and see you in a month or 2. I'm going to be pregnant. So I am happy to report, though, Kay was able to achieve a natural pregnancy about 9 months after starting care with our clinic. So again, if we look along that timeline, the first couple of months of evaluation, another few months of fine-tuning things and making sure that we had everything just right. And within a couple months after that of getting her levels optimized, she was able to conceive naturally. Again, this is somebody who had gone through 6 rounds of Clomid, multiple rounds of IUI, multiple rounds of IVF, was told unexplained infertility, sorry, we don't have anything else for you. And by correcting these underlying issues, she was able to conceive naturally. So Kay's standard IVF treatment that she received, 30 months, over $47,000, no answers for infertility. She did experience also significant side effects from the excessive hormones and ovarian hyperstimulation. And at the end of it, her diagnosis was unexplained infertility, no baby, And she still had frozen embryos. And for a lot of people, that creates this very difficult moral situation. What do we do with these embryos? How do we manage that? In Kay's case, she did end up, they went through enough cycles that they implanted all of the embryos before she came to see us. But for many people, they don't take that into consideration, that if they go through IVF treatment, how many embryos are fertilized and what does that mean and what do we do with that long term? As opposed to radiant clinic treatment in Kay's situation in particular, and every case is a little different, but Kay ended up working with us for 9 months until she was able to conceive. She spent about $9,000. She had answers as to why she had issues going on with fertility, and we were able to target treatments with frequent medication adjustments so she didn't have the negative side effects from that. We discovered at least 6 new diagnoses for her. And at the end of it all, she had a healthy baby girl, 7 pounds, 4 ounces. She was born full term, I believe 40 weeks and 2 days. And more importantly, Kay had the ability to try and treat again in the future if she wants to conceive another time. We already figured out, here's the underlying cause. Here's how we can get there. It shortcuts it. So we're able to say the next time around, let's try what worked last time and go from there. But again, realizing that each time through may be different, we're still going to judge each cycle on its merits. So let's talk a little bit about success rates, because I know that's a really important piece for people. And I just want to be very transparent that the data that I received and the data that I got, and the best data that you can find on a national level, at least here in the United States, is through SART. So SART, it's the Society for Artificial Reproductive Technologies. And they report IVF data across the entire country. Now, if you are looking at a specific center, you can oftentimes dial it down to see what the rates are as far as pregnancy and live birth rates at the particular center that's local to you. I will say it is a little tricky to find good data, and it typically lags far behind. So right now, this recording is in 2025. Right now, the data that's available for a complete year is 2022. So it lags behind by a couple of years because of different reporting metrics and everything. So one thing that's really important to know is that when you're talking to a center for in vitro fertilization, many of these centers report their pregnancy rates when talking to potential clients, not their live birth rates. So that means they're not taking into account people who have a miscarriage or people who have a stillbirth or a preterm loss. They don't talk about those live birth rates in some cases. It also doesn't account for canceled or unsuitable embryos. So there's a section on this website as far as SART goes that you can look to see how many cycles were canceled, what did that look like, but many times that's not very transparent. It's not easy to find. If we go with nationwide average at best, and I want to give it the benefit of the doubt, at best, 50 to 60% overall success rate in women less than 35 years old. However, that does also come with an overall increased chance of twins and preterm birth. Now, I don't have national data. I haven't treated thousands and thousands of people at this point in time. However, we always provide transparent data. We are working on getting this published as well as posted to our website on a running basis. But first of all, we always report live birth rates. We absolutely do track our pregnancy rates. We absolutely do take every miscarriage seriously, and we want to track that, account for that, see if there's anything that we can continue to do better. But when we are reporting things, we're always going to report live birth rates. So our live birth rate at the clinic since opening back in August of 2023 is about 70%. And this is for all ages. And I'll show you the breakdown of that in a little bit. The other 25 to 30% of the time, people say, well, what about those other people? The people that didn't get pregnant. Of that 30%, when I look at a breakdown, sometimes clients decide to stop care. Sometimes people say, you know what, this is not for me, or I don't want to continue, or I choose to do something else. Sometimes clients decline recommended treatment or evaluation. So for some people, that means, hey, maybe I recommended that they go get evaluated for endometriosis surgery, but they don't want to do that. Or sometimes I recommend, hey, you need to take this and such different prescription strength medication in order to help boost your progesterone levels, but they don't do that. And so when I look at those on a case-by-case basis, there's always a reason that I say, oh man, we could have done more, or if we had done this, the outcomes may have been different. And then the last one is that we do have a fair amount of clients that end up deciding to foster or adopt. And that's a beautiful thing, and that certainly happens. But I think it's important to include all of those people in our numbers, because it's not just the people that get through an entire successful program with us. It's about realizing that life happens in the midst of trying to conceive, and sometimes intentions change, and sometimes your personal preferences change, and that is totally okay. So wanted to share some information here. This is the info directly from that SART database that I had mentioned. And this is the data from 2022. Now, this is a really busy slide, but I'm going to break it down for you a little bit. First of all, I want to call out age of woman is broken down at the top here. So less than 35. Again, this is going to be the highest success rate when we're looking at all of this data. And then they space it out from there as far as all the way up to any woman that's over the age of 42. So if we look at really kind of the main key to look at is live births. So this is going to be a woman who is utilizing her own eggs. How often was IVF successful in 2022? So women less than 35 years old, 51% of the time had a live birth. If you increase that age range even a little bit, 35 to 37-year-olds, 40%. If you get up 38 to 40-year-olds, 27%. And then after age 40, it drops off significantly, 14%, and over age 42 down to 4% success rates with IVF. The other things that you can break down here is you can look at percentage of live births that were single pregnancies versus twins. And so I've listed here at the bottom the national average in the US for 2022. Twins was 3.1% across the board. So twins not terribly far above the national average, but it does increase a little bit. The other thing that's really important to pay attention to is of these cycles that were IVF cycles, how many of these pregnancies went full term versus preterm. So again, full term, around 85 to 86% across the board, preterm, somewhere between 11 to 12 or 12.5%, depending upon the age. And if we look at the national average, preterm birth is generally around 10.5%. So although they are a slight increase, it still is poor outcomes, live birth rates, like I said, in this case, less than 35-year-olds, 51%, with a slight increased risk of twins and preterm birth. Some people ask, well, what about donor eggs? What if my eggs are, if I've been told my eggs are old or I have ovarian failure? Wouldn't that be better? And so really when we look at donor eggs in regards to IVF, again, we're going to look at this live birth rate. So depending upon what you're utilizing, fresh donor eggs, frozen donor eggs, thawed embryos, donated embryos, again, we don't hit any better than about 46%. And again, this is nationwide data. So certainly there may be some centers that are a little better than this and some that are definitely worse than this. But across the board, I think it's important to know this data and to realize that the statistics out there are real. Again, we see with donor eggs a significant increase in the gestation of twin pregnancies. So we're going to compare this to rates at our clinic. And what we've done is this is the data as of February 2025. And so I'm going to break this down a little bit because our data looks a little bit different as far as how we report it. So first of all, this is clients that have worked with us for more than 6 months. And this is important because we do always have new clients that are coming to us. And generally we say it takes at least 6 months before we can figure out what's going on, get somebody charting, get their lab evaluation done. So basically anybody that's been working with us for more than 6 months, and again, this is on a rolling basis, for more than 6 months at this point in time is at 78. Now, we do have clients that drop out less than 4 months, and sometimes people come to us for one evaluation and decide this is not what we're looking at. And generally, if they're dropping out less than 4 months, they typically have not even started on treatment. Oftentimes, they may have been recommended treatment, but decide at that point in time it's not for them. So of those, we've had 13 of those, which is about 17% of our population. So with our remaining clients, meaning people that have stuck this out for more than 4 months, then we get that to 65. So we've created this as our new 100%, right? So 65 clients that have said, okay, yep, we're going to do this. We're going to do the full program. We're working with you for more than 4 months. Of those 65, we've had 45 pregnancies, which is at about almost 70%. Of those pregnancies, 3 were preterm births, so 6%. Again, preterm birth rate is at 10.5% nationwide. Our preterm birth rate is at 6%. And then non-identical twins, 1 set of non-identical twins. So ratio is at 2.2% compared to 3.1%. Now, the reason this is important, non-identical twins, is because a lot of times when we're giving some of these ovulation stimulation medications, it can increase the number of eggs that are being released, and that can lead to non-identical twins. If it's identical twins, that means they came from one egg and they split on their own afterwards. And so that has nothing to do with giving stimulation medications like letrozole. So typically we still would look for that in our data, but we do differentiate because that makes a big difference to make sure that we are not the cause of releasing multiple eggs. Now, in fairness, I realize my numbers are small. I realize we don't have a ton of clients. At this point in time, it is just me in the clinic. But I do think that this is very, very telling to say, how do we achieve such improvements on numbers and reduce the risk of preterm birth and non-identical twins? And I think that's just really a validation of how are we making a difference here from this root cause, evaluating those pieces and really digging in and finding how can we improve our overall outcomes when it comes to pregnancies. So this all sounds great. What do I do now? So first and foremost, if you are not already charting with a fertility awareness charting method, this is going to include things like Chart Neo, which is Neo Fertility, Creighton Model, FEM, Symptothermal, Marquette, Billings method, something that is an actual scientific-based fertility awareness charting method. Get started with charting. We have so many charting instructors that work with us that are just passionate and brilliant when it comes to teaching you how to chart your cycles, how to identify when am I ovulating, when is my fertile window. And these instructors are able to teach and educate you in any state or country. We actually do have international clients that we see. And so we would love to get you plugged in with working with one of our charting instructors. The other thing you can do is schedule a free discovery call with me. So you can go to our website, radiantclinic.com, and at the top right-hand corner, there's a link that says book free discovery call. You can get on the phone with me to decide, hey, is this the right fit for me? What does this look like? What do I need to do to work with you more? We are currently accessible for medical consultations in 8 different states. Those are all listed on our website. And we are continuing to expand access to additional states. So if you're in a state that's not listed as one that we're currently serving, we'd still love to hear from you to see what does it look like for me to obtain medical licensure in another state. It's typically pretty straightforward, but able to say, how can we work together to get you the answers that you deserve? Additionally, if you are interested in working with a hormone or a health coach or our dietitian, they are able to see clients in any state. And we'd be more than happy to get them on the phone with you as well to have a free discovery call to learn if those services are right for you. And then the final thing that you can do is follow our podcast. Again, Cycle Wisdom, like I mentioned. This is the screenshot that you'll see for Cycle Wisdom. And you can go there. I put out weekly episodes. They're typically pretty short, 15 to 20 minutes, but you're able to then dial in to say which episode applies to me and my particular situation. The other thing is this QR code. You can click on it and you can learn more and stay up to date. It will link you to being able to book a discovery call. It also will show you towards our social media pages. So Facebook and Instagram, we're posting there frequently. It also allows you to get to our podcast episodes if you're having a hard time finding it. So would love to be able to connect with you. I am hoping to hear from many of you on those discovery calls. Again, they are free, no cost to you at all, just to ask your questions. We don't offer direct medical advice, but able to kind of talk through your situation to see, is this a good fit for you? What else can we do to help you to move in the right direction of getting the answers that you need and that you deserve in order to be able to figure out your fertility concerns? So I look forward to chatting more with you soon. I am so excited to have shared all of this with you. And if anybody has any additional questions, feel free to reach out to us via our website. There's a comment section there. And this episode will be available as a replay. So make sure that you share this with friends or family members who maybe weren't able to attend tonight. Thanks so much. Have a great evening.